Hello, it's Audrey Vernick with the Brain Recovery Project, and this is part 2 of our presentation on comprehensive evaluations after epilepsy surgery. What assessments does my child need? So I'm jumping right in today without a lot of preamble. Hopefully you all have already viewed part 1 of this presentation, where I went in great depth about the neuropsych, psychoeducational, and educational assessments and the differences between different types of assessments, which is important. I'll be referencing that throughout. So we're going to start today with hearing and listening. So when we think about hearing and listening, it is really one of the most important areas to understand for a child in an educational setting, particularly after a temporal lobectomy, a corpus callosotomy, or any brain resection that disrupts the language pathways. I spoke about this before. We often think about one region of the brain controlling a function, but any disruption to the networks or the pathways of information in the brain can cause a deficit. So even a child who has an intact temporal lobe and a corpus callosum could still have an auditory processing disorder, for example. So auditory function is basically the ability to hear and listen, and it's one of the key issues our kids face in their educational setting. We could and should spend many hours on this topic, but I don't have hours today, so I will go as quickly as I can to give you an overview. So hearing and listening are two different functions. There's acuity, which is what the ears hear, that hearing sensitivity. And then there's central auditory processing, which is how does the brain hear. So the ear is made up of 3 parts, the outer, middle, and inner ear. This is all peripheral hearing. So the child's peripheral hearing could be intact. The ears, the cochlea, everything leading up to the brainstem could be fine. Hearing in this scenario is a passive sensory process where the person detects sound. So you don't have to try to hear something. The standard assessments only look at the peripheral system. And so the assessments for peripheral hearing, they look at peripheral auditory disorders such as conductive, sensorineural, mixed hearing loss, etc. These disorders can affect a person's ability to hear and understand speech and background noise to varying degrees, which is really the primary area of struggle we see in children with central auditory processing disorder, but it's different when it's the peripheral system versus the central system. Any child with hearing loss can have delayed development in language and speech, and it's really important to understand early intervention for children with hearing loss. So just because your child had brain surgery for epilepsy and we're concerned about the brain-based components of hearing, it doesn't mean we don't also have to look at the child's peripheral hearing, because there could be both disorders. So these types of tests are done either by the school nurse, the child's pediatrician, or an audiologist. These are the pure tone testing is the test where you put earplugs in and the child hears a beep and has to raise their hand. This only indicates whether tones were heard, so these single beep tones. It doesn't tell us anything about higher language function or anything along that line. And it goes into both ears at the same time. So these type of pure tone tests don't tell us if there's a hearing loss in only one ear. It doesn't give us any information on whether or not the child makes sense of linguistic information. So there's play autometry, the visual reinforcement audiometry are the tests for younger children. And then bone conduction test is used to rule out, like if there's fluid in the ear or some kind of blockage. Speech testing can look at how well the child listens and repeats words. There's tests of the middle ear. So the auditory brainstem response, that's a pretty common test used in newborn screening programs. Again, this is just a response test. It's one sound level, one loudness level is checked, and it might also be used for an older child who's unable to complete a typical hearing screening because they don't have the ability to respond. And then there's also something called autoacoustic emissions, which has to do with the vibration of the hair cells on the ear. These things have to be done or are determined before you would do further assessment. for auditory processing. You need to rule out that these measures are normal. There's some other measures that are done by maybe the speech therapist or the special education teacher. These are sort of screening measures or tests for children who are truly hearing impaired. So these are also different than what we're going to talk about at length, which is the central auditory processing. So the next thing we need to understand is the auditory processing. This is in most basic terms, it's this impairment and any breakdown in the parts of the brain that send, interpret, and organize sounds. So when you think again about the brain and the functions of the different regions of the brain and those networks and pathways, that's where this breakdown occurs. So basically, it's how does the brain process what the ears hear? So listening is an active process. We talked about how hearing was passive. Listening is active. It involves detection and interpretation. What does the brain do with the information received by the ears? So you have to actively attend to discriminate different sounds, particularly in speech. And the ability to hear and listen provides us with an enormous source of information. This forms a bridge between the world and how we interact with it. And in school, hearing and listening allow the child to maintain a high level of concentration with little effort, to communicate effectively with instructors, to register information accurately. And in social situations, listening allows us to participate in conversations and interact with others in both loud and quiet settings. So these functions can be impaired if there's any damage to the auditory cortex, which is that little fold in the brain. It's on both sides, and that's where the brain processes sound. You can see the arrow pointing to the primary auditory cortex. So I just want to clarify here that it can be referred to in different ways. Overall, damage to this region can result in what's called a cortical auditory impairment. We've heard the term often, many of us have heard the term cortical visual impairment. It's the same idea. The cortical auditory impairment can result in what's known as central hearing loss, but we most commonly refer to it as a central auditory processing disorder. So any surgical procedure that interrupts the normal function of the auditory cortex can lead to a central auditory impairment. So that's corpus callosum, temporal lobe, or again, interruption to blood flow of any part of the brain. And other risk factors for central auditory and processing disorder include epilepsy itself. Research on children post-hemispherectomy indicates that all have some degree of cortical auditory impairment. And a typical child with CAPD, because in schools there are children that haven't had brain surgery that may have a central auditory processing disorder. Some children are born with the disorder. They may develop the disorder because of other reasons. It's different than a child who has a central auditory processing disorder as a result of brain surgery. If they have a surgically acquired impairment, there will likely be a permanent amount of auditory impairment. And then the severity varies based on a number of factors. And therefore, this needs to be monitored over time with repeat assessment. And the extent of the impairment will vary from child to child. So here's a list of some of the things you may see in a child with a central auditory processing disorder. They may have difficulty understanding speech in a noisy environment, in the presence of ambient noise, so like nonsense background sounds or competing speech. It's a condition where the brain is unable to process or make sense of incoming words or sounds properly. And the children who struggle to listen in these environments may struggle to make meaning of the language they hear on a daily basis, which in turn set them at risk for literacy challenges. These children might do well in a simple auditory environment, but be exhausted by prolonged or complex noises. I know for my son, whenever we go to a loud restaurant, after about 5 minutes, he says, I need to step outside and take a break. Difficulty with sound and symbol associations, such as in phonics. So the accurate representation of speech sounds is a really important aspect of learning to link sounds with letters. And this is a fundamental building block of reading, which we discussed at length in the previous presentation. Some of these children will have difficulty following directions with auditory attention to detail, distractibility and inattention, following conversations, understanding humor, They may struggle with abstract information, such as math word problems. These children might be easily distracted or bothered by loud or sudden noises. They may get upset in noisy or other complex environments. So this is generally misophonia or hyperacusis. You might see an auditory sensitivity, but you have to be careful because there can be just a sensory processing concern that doesn't come from the auditory pathway. So again, this is where appropriate assessment is so important. And the child also may have difficulty localizing sound. This is so important in our kids who've had epilepsy surgery, particularly if they also have a vision impairment as a result of their surgery, because if you can't tell where the car is coming from and you can't see where the car is coming from and you're trying to cross the street, that can be very dangerous. So who should assess for essential auditory processing disorder for hearing and listening? There will be a variety of assessments that will take place. The preliminary assessments that your child has already undergone by this point, the psychoeducational or cognitive assessments, may detect those auditory processing concerns. The speech and language pathologist should be evaluating and diagnosing problems in the linguistic processing of the auditory signal. So basically, they're identifying language disorders that occur in association with central auditory processing disorder and other receptive language disorders. Unfortunately, in my experience, what I've seen is that school district speech and language pathologists are not well versed in central auditory processing disorder. And so even if we bring the results to them that the child has a central auditory processing disorder, they may not understand how to evaluate for that or how to support that child. So in that case, you really need to make sure you're working with a speech and language pathologist who's well versed in this disorder. An audiologist is the only person who can make a diagnosis of CAPD, and they are the ones it has to be someone who specializes. So again, even audiologists, not all audiologists specialize in central auditory processing. So you need to work with an audiologist who has that area of expertise. There can be psychoeducational measures that are done on auditory processing skills, as I mentioned before. Listening comprehension, verbal comprehension, auditory attention, reasoning, and then even literacy assessments that might be done by the special education teacher. The speech and language pathologist will also do a number of assessments. So auditory processing refers to the ability to identify, isolate, blend, substitute, and analyze speech sounds. And that's the domain of the speech and language pathologist. So if the child struggles to identify and isolate those speech sounds, this warrants further assessment. And remember, challenges with auditory processing may impact academic success in reading and spelling, following directions, and a number of other issues. Speech and language pathologists use the term receptive language disorder or abnormal auditory perception. So they should be evaluating the child's phonological awareness, their auditory vigilance, and their auditory memory, which is the test of the prosodic aspects of speech, such as rhythm, intonation, stressing keywords, that sort of thing. So here are some of the assessments that might be done. The APAT, which every test, by the way, will have an acronym. I'm giving you the full the full name of the test as much as possible, but the auditory processing abilities test assesses how well one understands what one hears. This is still different than a full auditory evaluation by an audiologist for central auditory processing disorder, which I'll explain next. So this assessment might look at phonemic awareness, complex sentences, passage comprehension, and it is considered a comprehensive assessment of auditory skills beyond hearing acuity, according to the test manufacturer, but it's still not a comprehensive evaluation for an auditory processing disorder. So you always want to be clear that that the child is being tested for what needs to be tested. And in this case, we need to make sure that we have the appropriate assessment. So let's look at what the audiologist is going to do. The audiologist is going to take a thorough case history, looking at all the previous complaints and issues that have come up in the past. Then they're going to do that thorough audiologic evaluation of the peripheral auditory system, which I explained earlier, all the pure tone testing, the tympanogram, all the different tests to rule out anything that might be getting in the way of the central system being able to process information. You can have a peripheral auditory deficit and a central auditory deficit. If you have a peripheral auditory deficit, it's harder to assess, and it also almost always indicates that there will be a central auditory deficit because the cortical auditory system is then deprived of auditory information. So when you think about it, if you have a peripheral hearing loss, imagine that you have earphones on all the time, noise-canceling earphones on all the time, but you're trying to hear what's happening in the world, not what's coming through your earphones. And maybe you even have loud music playing and you're trying to hear what's happening in the world. That's what the peripheral hearing loss does to the central auditory system. It prevents it from receiving that information. Now, the next step would be the audiological evaluation of the central auditory system. And this is in two components. There's a behavioral assessment, which looks at the functional capabilities of the auditory system. And then there's also an electrophysiological assessment, which looks at the neural processes in the central auditory pathway. The ABR that we mentioned before, that newborn screening assessment, is also an electrophysiological assessment. So auditory processing consists of complex tasks requiring both sides of the brain. Many children after brain surgery for epilepsy who have damage to the temporal lobe, the corpus callosum, or any of those pathways, they may have audiological symptoms, as I described, but they have normal pure tone audiograms. They might do well on all the tests of sound and quiet, where they listen to different environmental sounds and words without earphones or in a soundproof booth. But where they fall apart is when there's competing noise coming from the environment, that's sound and noise, or any environmental sounds or words coming into both ears at the same time, the dichotic listening. Then their hearing is severely impaired, hearing and listening. So the prerequisites for a traditional central auditory processing disorder behavioral test battery include that the child has normal hearing sensitivity, which I mentioned, normal cognitive abilities, an IQ of 80 or higher, appropriate speech and language skills, and a minimum age of 7 years due to the age norms used to determine normal function. This is a pretty high bar, and many of our kids may be 3, 4, 5 years old. They may be older and have a lower IQ. They may not be able to be assessed because they are not able to respond to behavioral cues. They're not able to sit in a sound booth and undergo a battery of tests. If the child doesn't meet these criteria, there's a couple of options. There are some screening measures that can be done for the younger child, I would say as young as age 3, that can indicate the presence of the disorder. These measures might be sufficient to establish supports and accommodations for the child. And you can also consider the electrodiagnostic testing. Those electrodiagnostic tests look at the neural processes in the central auditory pathway and give information about the integrity of the pathway. I just want to state here, I don't think I have a slide on this. If the child can't participate in any of these tests, we have to presume that they have a central auditory processing disorder if the temporal lobe was removed or disconnected, or they have a corpus callosotomy. So audiologists look for five main problem areas in kids with central auditory processing disorder. So the auditory figure ground, that's where they can't pay attention if there's noise in the background. And that's where these noisy and loosely structured classrooms that most of our kids are in are very, very frustrating. We like to think of classrooms as quiet places, but they're filled with the sounds of heating systems, chairs shuffling, children talking, noises from the street, and all of these sounds compete with the teacher's voice. Auditory memory problems. This is when a child has difficulty remembering information such as directions, lists, study materials, and that can make it hard for the child to follow directions and learn during lectures and discussions. Auditory discrimination problems. This is when a child has difficulty hearing the difference between words or sounds that are similar. This will affect the child's ability to learn to read and spell and make it difficult to understand spoken language. Auditory attention problems, this is when the child can't stay focused on listening tools long enough to complete a task or requirement. Kids with CAPD often have trouble maintaining attention, although their health, motivation, and attitude can also play a role here, and also ADHD, which I'll discuss later. And then auditory cohesion problems. This is higher level listening tasks. They have difficulty drawing inferences from conversations or understanding riddles or comprehending verbal math problems. So there's a number of tests that, these are behavioral, that assess the functional capabilities of the auditory system and determine the specific areas of deficit. Behavioral testing means that the child has to actively participate in listening and answering. A good battery of tests should be thorough and try to assess the child's major auditory processing skill areas to understand the specific areas of weakness. The test should include both verbal and nonverbal stimuli to examine different aspects of auditory processing. For example, there's one measure where the child has to hum a response and label it verbally because that requires different functions of the brain. If the child's on medication for ADHD, the child should take the test with the medication. And remember, only a trained audiologist can perform these tests in order to make a diagnosis of CAPD. And it has to be done in a sound booth in order to control the sounds coming into each ear separately and together. If the testing is done in poor acoustic conditions, the results can be variable. So I would dismiss those results. So the tests are speech and noise, that's looking at that auditory figure ground, the ability to discriminate speech in the presence of background noise. Auditory discrimination, which is the ability to differentiate the different acoustic stimuli, so basically identifying phonemes. Dichotic listening is the ability to decipher competing meaningful speech or sounds presented to each ear at the same time. So again, that's what's happening in the classroom when you're hearing multi-speaker babble, when you go to turn and talk in your first grade classroom and you have little groups of 4 talking about their day, that's going to measure the skill ability in that area. Your acoustic scene, this is the ability to tell where the sound is located, lateralization and localization tests, the ability to accurately find the side or origin of the sound, being able to hear cars coming at you when you cross the street or a dog barking. Temporal processing, which is the ability to analyze acoustic events over time. That temporal refers to time, how the brain interprets timing cues. This has to do with compressed sound or muffled sound. Can you hear the train conductor announcing your next stop, for example? And then auditory closure. This is the ability to fill in auditory information when a portion of the message is missing or distorted. So the diagnostic criteria are generally that there is a deficit in one or both ears of at least 2 standard deviations below the mean on 2 or more tests on this test battery. And diagnosis might be withheld until the performance falls before 3 standard deviations, but 2 standard deviations is generally the norm. And inconsistencies across tests might present other deficits, even if the central auditory processing deficit criteria is met. So again, sometimes if there's a complexity of other diagnoses, or the child is too young, or they aren't able to participate, they can do these electrodiagnostic tests. They look at the brain and see how the brain detects and interprets speech sounds, how the auditory cortex responds to these sounds. Generally, they're passive. The child can be sedated or asleep for many of these tests, most of these tests. They're not very common because they're expensive tests, especially if they're done under sedation, but there is a large amount of research supporting their use in assessing central auditory function. I'm not going to explain what each test does, but these just to familiarize yourself with the names of these tests. And they're not able to give a formal diagnosis of CAPD, but they're valuable in looking at the central auditory nervous system. But one caveat is that these tests cannot determine deficits in dichotic listening. That's the one area that they can't measure, and that's the primary deficit we see after surgical resection of the temporal lobe. So just a qualification there. So we want to remember that any child after hemispherectomy, temporal lobectomy, corpus callosotomy, TPO will have some deficits of central auditory function as a result of the auditory centers of the brain being removed or disconnected. So if the child has had one of these, you have to assume that the child has some impairments related to dichotic listening, sound lateralization, and sound localization. And the ear opposite of the removed or disconnected temporal lobe is considered massively suppressed in dichotic listening environments. That means any noisy environment, they're going to struggle significantly. So the next thing we need to understand is their functional ability to hear and listen in a classroom setting. So now we know if they have a peripheral hearing loss, now we know the extent of their central auditory processing impairments. Now we need to know what happens when you take them into a classroom and try to teach them something, anything. So these are done by a specialized audiologist, the school district audiologist, perhaps the teacher for the deaf and hard of hearing. There's two different evaluations that you may request. One is a functional listening evaluation. This is to determine the child's ability to access auditory information and instruction in the classroom. What happens is the administrator of the test is going to stand in front of the child at 3 feet, right in front of them, is going to stand 6 feet away, 9 feet away, 12 feet away. The evaluator is going to stand behind the child at different distances. This is generally done in an empty classroom in total quiet. What they're measuring is, does the child need the speaker to be standing in front of them, and how close? And can the child also repeat information back when they don't see the speaker at all? So say the evaluator is standing behind the student way in the back of the room. And this will tell us how does the child respond to verbal information. The complexity would depend on the child. It might just be repeat these words back to me, these 3 words, or it might be, I'm going to read you a paragraph. You need to tell me what it was about for an older child. We need to know, does the child need the teacher to be standing right in front of them, looking at them and giving visual information as well as verbal information, such as watching the teacher speak, watching their lips move, and learning from the way they're gesturing and moving? Or can the child do well when the teacher's in the back of the room and much further away? Then the other measure is a classroom acoustical assessment, which is just to determine if the learning environment meets the acoustical standards for learning. And this is based on the something called the American National Standards Institute, which sets the standards for the maximum dBA or decimals in a classroom. And this assessment looks at the size of the classroom, the type of ceiling, the walls, the doors, and the windows, if there's furniture and carpeting, the HVAC system, any noise from adjacent rooms in the hallway or playground noise, construction noise, any other noises. And there's sound level measurements taken throughout the room using specific audio tools, and they'll make 4 assessment points in the room. What I find is I see this done in empty classrooms, and it can give you a baseline level. I have seen these measurements taken where the classroom itself empty was not meeting the ANSI criteria for the maximum sound level before anyone even showed up in the room. But I would like to see, for our children with auditory processing deficits or hearing loss, I'd like to see these measures done in an empty classroom, and then also when the class is in session. You can look up online what the maximum decibels are that are allowed. In general, when the HVAC is turned on or there's playground noise, that's when we have the problem. So I have seen in a combination of these assessments that then the child is required to receive their reading instruction, for example, if that's where they struggle the most, with the teacher right in front of them, no more than 3 feet away, with the HVAC turned off and not during recess, for example. So you can see how this all gets tied together. I want to make a point that central auditory processing disorder may be confused as ADHD. There is a difference between ADHD and CAPD. They are similar but different. So ADHD, we see inattention, distractibility, hyperactivity, restlessness, impulsivity, and interruptions or intrusions. Whereas in CAPD, we see more difficulty hearing and background noise, difficulty following directions, poor listening skills, academic difficulties, poor auditory association. Where the similarities are that distractibility and inattentiveness. But the important thing also to note is that after epilepsy surgery, your child may have both CAPD and ADHD. But if ADHD is being talked about and you feel that the deficits you're seeing are more on the CAPD list, then that's when you want to request that evaluation. So here are the key takeaways. This is a very important component, and this is why I wanted to spend a lot of time on this, the way we spend a lot of time on reading. Auditory processing refers to the ability to identify, isolate, blend, substitute, and analyze speech sounds, which is the foundation of reading. Central auditory processing disorder is an auditory issue that has to do with brain function. It's not a cognitive disorder. It's not a speech or language disorder. It can be in conjunction with those, but that's not what it is. This would occur with any child after epilepsy surgery that disrupts the networks of the brain, removes or disconnects lobes of the brain, such as the temporal lobe, which houses the auditory cortex, any disconnection of the two hemispheres of the brain. These children may have a marked speech and language impairment. They may have a significant learning disorder, and they may experience a very disabling form of central auditory processing disorder. We know that children who struggle to listen in noisy environments may struggle to make meaning of language, which can put them at risk for literacy challenges. This is part of the hearing loss, deaf and hard of hearing literature. It's particularly important for academic achievement in the areas of reading and spelling, as well as following directions. If auditory deficits aren't identified and managed early, these students with central auditory processing disorder face significant academic, social, and emotional challenges. It's very, very frustrating for kids with central auditory processing disorder to spend all day long in noisy classrooms trying to learn. They become very, very frustrated. So this is a really important assessment piece that needs to be looked at in depth with a comprehensive evaluation. So next, we're going to talk about vision. This is another very complicated and very important component of any child's education and needs to be looked at with comprehensive assessment. So the visual system is a complex part of the central nervous system, again, the brain, that incorporates the eyes, the ocular pathways, and the brain to produce and interpret sight. It requires consistent communication between all of the individual anatomical pieces, and as well as the vestibular system and the musculoskeletal system. It's complicated and it requires many different skills. It requires acuity, which is how sharp the child's vision is, ocular motor control, which includes eye tracking, the eyes working together, eye focusing, visual processing, which is the brain making sense of that visual input, visual motor integration, which is the visual processing and the visual motor working together, visual fields, which many of our kids may have visual field loss after epilepsy surgery. And then we want to wrap it up with looking at functional vision. How does the child use their vision in school? And we'll look at the assessments that are done there. So neurological changes to the occipital lobe, which may lead to hemianopia, the temporal lobe, which may lead to quadrantanopia, the parietal lobe, which may lead to visual agnosia, frontal lobe, which affects attention and visual processing, the motor strip, which affects ocular motor control, and all of those networks and pathways that we've discussed. Any of these can adversely affect the way your child functions in their activities of daily living, their thought processes, their emotional behavior, speech ability, physical changes, impaired motor function, and problems with the visual system. So I want to note here that visual impairment, including blindness, means an impairment in vision that even with correction adversely affects a child's educational performance. This is from IDEA. The reason I put this quote in is that I've worked with many families who did not know that their child qualified as deaf or blind. So you have to remember the definitions under IDEA for eligibility are different than a medical diagnosis. So your child may qualify as a child who is visually impaired under an IEP, or even a child who is hearing impaired due to central auditory processing disorder, but they might not be thought of as deaf or blind by your medical doctors. This matters because you want to make sure your child is receiving appropriate placement, appropriate interventions and services, etc. So again, goes back to that comprehensive evaluation. What do we know about the child? So the important thing to note is that for all of these assessments that I'll be discussing from here on out, the child is always going to require a multidisciplinary assessment team, because when you have an acquired brain injury from epilepsy surgery, many of the brain processing systems have been affected. What I want to point out here, though, is that in most school systems, the psychologists and many other individuals who conduct these assessments have little or no experience with children with visual impairments. Visually impaired students are very rare, and most of the standard assessment tests and instruments that they use aren't geared to children with visual impairments. So it's very important that every assessment that is done, if the child has a visual impairment, is with the teacher of the visually impaired, so that they can provide suggestions about appropriate assessment procedures and help interpret the results. So we're going to start with that central vision, visual acuity, which looks at nearsightedness and 20/20 vision, that sort of thing. It measures whether a stimulus is being seen, not necessarily if the information is being understood. So most children's first eye exam is in school where the child reads an eye chart, or maybe at the doctor's office. And the nurse might say something like 20/20 vision in both eyes, no visual concerns. So all that tells us is that the child has looked at an eye chart and read the letters at 20 feet, has demonstrated the ability to look straight ahead from the right distance without things becoming blurry or illegible. And so that just demonstrates that visual acuity, which is the ability to see with acceptable clarity. It doesn't tell us about reading distance, which is 6 to 8 inches, computer distance, or social distance. Every 8 inches is a new place for the eyes to focus and make sense of the images coming in. Most vision problems are not detected during these basic vision screenings through school physical or routine pediatric health evaluation, because it doesn't assess all of the complex areas of vision and visual function. A functional visual assessment, this is what the school will do. This assesses how the child uses vision in everyday life, and it will assess areas of concern in safety, navigation, and reading, for example. It'll include a learning media assessment, the expanded core curriculum needs assessment, an orientation and mobility assessment, which we'll discuss after vision, plus assistive technologies designed for people with visual impairments or blindness. These are done by the teacher of students with visual impairments, also known as a teacher of the visually impaired, so TSVI or TVI, and the orientation mobility teacher or specialist. So the key assessments that will be done are the functional vision assessment, which looks at how the child uses their vision, a learning media assessment, which examines the way in which your child uses his or her senses to obtain information and helps determine the most effective ways the child can be taught reading and other skills. And then the expanded core curriculum, plus orientation and mobility and assistive technology. So this is what a functional vision assessment should consist of. It's very comprehensive, as you can see. It must include recommendations. All evaluations done by school district evaluators or outside evaluators should include recommendations. They're going to look at how the child uses their vision. This is visual efficiency. How are the extent to which they use their available vision? They're going to look at how they use their vision for near, intermediate, and distance tasks. This is an ongoing process because a child's vision and abilities can change over time. A functional vision assessment should be repeated periodically. For our kids who've had brain surgery for epilepsy, this assessment should also consider how the brain interprets visual information. Their visual impairments might be brain-based, so we'll discuss visual processing next. So the learning media assessment is going to look at information on the use of the sensory channels and the current use of their media. So what are they currently using to read, and what is their academic achievement? What is their reading legibility? If the child is reading, the vision teacher should be conducting an assessment of their reading ability to see how they're doing with their current, the current media they're using. And again, they have to make recommendations for the appropriate media or medium, what instructional materials and methods are going to be used for the child to access their curriculum. And it would be preceded by or include a functional vision assessment and all the clinical information documenting the medical information and, again, ongoing assessment. I just want to briefly touch on the expanded core curriculum. Oh, the dog is barking. The joys of working at home. This was an added curriculum that was added onto the Common Core. It doesn't replace the Common Core, it adds to it. It's needed by students with vision loss in order to be successful in school. And I just want to note that these are concepts and skills that often require specialized instruction for students who are blind and or visually impaired to compensate for their decreased opportunities to learn incidentally. So when you look at this list of the expanded core, it's, you know, compensatory or functional academic skills. What are their communication modes, orientation, mobility, their social interaction skills, their independent living skills, recreation and leisure, career education, assistive technology, and visual efficiency? How are these all being supported with specialized instruction in relation to the child's visual impairment? So an expanded core curriculum assessment would include that basic eye exam, the functional vision evaluation, and all the additional evaluations that we've discussed. And these all need to be data-driven evaluations, and they have to be formal and informal combined, which we discussed in detail in the previous part of this presentation in part 1. So next, this is really the most important component for our kids. We're looking at ocular motor control, visual processing, visual motor integration, visual fields, and I'll also talk about cortical visual impairment. So in terms of the visual skills needed for academic success, I'm going to break it down into the 3 main areas of ocular motor control, which is eye movement, visual perception, which is visual processing, and then visual motor integration, which is combining the two, the foundational visual skills in conjunction with those motor skills. So for ocular motor control, this is the ability to physically move the eyes using the eye muscles. The eye movements have technical terms such as visual saccades, pursuits, convergence, divergence, etc. Ocular motor issues will occur if the motor strip has been damaged. So the child will have issues. I call it CP of the eyes. So we all know when you have cerebral palsy that there can be a deficit depending on where the motor strip damage occurred. If it's on one side, then the child will have a hemiparesis, etc. It's the same thing with the eyeballs. There are many muscles that control the eye. Visual perception or visual processing. This focuses on the brain's ability to organize, interpret, and understand the information received from the eyes. It's about how we think with visual and spatial pattern information, and it impacts activities such as doing puzzles, solving mazes, interpreting a graph, and this influences academic achievement in the areas of advanced math, and then also orthographic processing and reading and writing. And then visual motor integration describes the ability to use all of these foundational visual skills in conjunction. So gross visual motor is moving yourself through space without bumping into things. Fine visual motor is writing, texting, doing other small close-up things like sewing, with using your vision with accuracy. It's the ability to interpret visual information and produce a precise motor response. So in the classroom, this is copying shapes, producing legible handwriting, using scissors to cut along a line. It can be exhausting to try to use all of these skills at once when you think about a deficit in any area. So the importance of eye movements or ocular motor control and reading. School is for learning, and reading is how we learn in school. Reading is the most complex ocular motor activity that we use daily, that our children will use daily in school. And reading print involves that adequate vision and the neurologic ability to identify what's seen. So is your brain receiving those efficient coordinated images from the two eyes working together? That eye movement is related to reading speed or fluency, which is related to reading comprehension. And ocular motor deficits can significantly affect reading after hemispherectomy, corpus callosotomy, or any motor strip disconnection or resection. So I'm going to show you, if I can here, let's see if this is going to work. This is the example of a reading efficiency test using a readalizer. So what that test was looking at was the types of eye movements involved in reading. So this is using a test called a readalizer. It's also referred to as a visograph. The teacher of the visually impaired and orientation mobility specialists at school don't have this equipment. They cannot measure reading efficiency and these types of eye movements. What's being looked at here are the saccades, which is the jumps between two objects. And the fewer the jumps, the more efficient the vision. When you're reading, your eyes don't scan smoothly. They jump from word to word. And the saccades include these periods of fixation that allow for decoding of the word. This happens when the eyes are paused, not when they're moving. So if you have these inefficient saccades, you're going to have problems. So this video that I just showed you shows a boy who was, my presentation is not on screen. I'm coming back here. Let me see what happened. Sharing your screen. I'm going to try again. Please tell me if you can see it now. Can you see my presentation now? Monica or anyone who's there, can you see the presentation now? Okay, great. We're back. Sorry about that. So what that was looking at, the video, which I hope you were able to see. If you weren't, I think it's posted on our website and I can post it, is looking at those eye movements. That child that you saw doing that test is my son. At the time he was in 7th grade. He had a reading he was in 8th grade. He had a reading comprehension level of 7th grade. Doesn't that sound great? Really good. I was super impressed that he was a 7th grade reading level with post-hemispherectomy. However, that reading efficiency test showed us that his reading efficiency was at the 2nd grade level, which meant that the effort that it took for him to read was incredibly laborious and fatiguing. So this is a really important piece of information to know, so we know what accommodations might need to be provided. Does he need audiobooks? Does he need to be read to? The effort of reading for him is intensely fatiguing. And if we didn't have that evaluation, we wouldn't have known that. So how do we assess all of these ocular motor, visual processing, visual motor integration, and visual fields? Again, a very robust team may be involved in testing all of these areas of function. So the assessment might be done by an optometrist who's like a PhD, OD. They're going to look at how healthy the eyes are and how they function. It might be a developmental optometrist who's going to look at how the eyes work together and maybe recommend vision therapy or prisms or other supports to compensate for the challenges. An ophthalmologist is an MD who's trained in the pathology of the eye and diagnosing diseases and maybe doing surgery on the eyes. They could correct a strabismus, that sort of thing. A neuro-ophthalmologist, this is the specialty that's concerned with visual symptoms resulting from brain diseases. They're going to take care of the visual problems that are related to the nervous system, that is, visual problems that do not come from the eyes themselves. They're trained usually in both neurology and ophthalmology, and they look at problems with the eye, brain, nerves, and muscles, but they're not going to offer that vision therapy or prism glasses the way a developmental optometrist would. So they may be good for diagnosing, but they're not going to be offering the therapeutic intervention. Which is controversial, by the way. A neuropsychologist, occupational therapist, and teacher of the visually impaired may also be involved. The neuropsychologist does a lot of visual perception tests on their evaluation. The OT is going to look at visual processing and perception issues and visual motor integration. And then the teacher of the visually impaired can look at those visual fields and functional vision, but they're not trained medical professionals, and there are some pieces of this that they cannot assess. So here's a list of all the things that would be assessed. They're going to look at the basic visual function, plus how do the two eyes work together, and they can do perimetry testing, and which I'll discuss, and visual perceptual abilities, those ocular motor challenges, etc. So I want to talk a little bit about the visual processing assessments that might be done. Visual processing is a higher cortical function. Although vision is fundamental for reading, the brain must interpret the incoming visual images. So here are some of the tests that might be done to look at the visual processing. They're going to look at visual discrimination, which requires the child to distinguish between symbols and to identify symbols that are alike or different. They're going to look at visual short-term memory, which measures the ability to recall shapes or pictures after a delay. They're going to look at visual sequencing, which is whether the child can remember shapes or pictures in the order presented, which is also it's referred to as visual sequencing. Visual figure ground, that requires the child to find or identify important details within a complex visual or busy background. Visual spatial relations tests require the child to picture how the parts of a puzzle form a whole or analyze and reproduce a complex design. So this is a list of some of the tests that might be done. You may see these tests listed under, again, what your occupational therapist has done or what the neuropsychologist or school psychologist has done. As I've mentioned before, you should look up the tests that are being done on your child, read about them, learn what they measure, find out, is this the right test? Is this test answering the question that needs to be answered? It may not be comprehensive. It may not consist of a comprehensive evaluation in the area that the child needs to be assessed in. So visual motor integration, this is looking at how does the student coordinate their hands with what they see. So on visual motor tests, the evaluator may ask the student to copy geometric designs, to draw designs from memory. They may have to arrange items or blocks in a particular orientation or follow a path with a pencil while staying along the lines. Your child may also have dyspraxia if the motor strip was affected, which can affect their fine motor skills. And if they have dyspraxia, they're going to have difficulty planning and completing the motor tasks. They might be clumsy and accident prone. Their speech might be delayed. Writing could be difficult. So the evaluation for dyspraxia should always include a neurological evaluation to rule out other conditions, including cerebral palsy. I would assume that by the time you've gotten here, the child has had a neurological evaluation, but I just want to mention that. So here are some commonly used tests to assess visual motor integration. Again, just familiarize yourself with these tests and look them up. So is it a cortical visual impairment? After brain surgery for epilepsy, after epilepsy surgery, if the visual pathways are interrupted and the child has homonymous hemianopia, that does fit the definition of CVI. A cortical visual impairment means that the eyes can see, but the brain can't. Cortical and visual impairment might have existed even before the surgical procedure, depending on the etiology. For some children who have certain brain conditions, there may have been a deficit beforehand. There might be complications after surgery, such as an infection or hydrocephalus that damages those visual pathways. Again, this is why we need ongoing assessment for these children. You don't get assessed once and then you're done. Our children are very, very complicated, and they may require evaluation every year in some of these areas, certainly every 3 years. Cortical visual impairment is sometimes misidentified as autism. Gordon Dutton, who's one of the world's leading researchers in cortical visual impairment, has stated that he's seen children who actually had CVI that were diagnosed with autism. This is why appropriate evaluation is so important. If the visual professional conducts the wrong kind of functional visual assessment, such as an ocular assessment for a child who's primarily affected by a brain-based deficit, they might be missing the deficits. Our kids might have both. If there's a poor assessment, the characteristics of the child's visual function will remain unidentified. So that means they can't appear in the child's statement of functional visual skills or in their goals or objectives. Environmental considerations won't be in the child's accommodations and modifications. Cognitive skills might be masked by the inability to understand what is seen. Again, they're going to have normal visual acuity. They look like they're seeing fine, but if we don't understand how they're processing visual information, they might be blamed with having a cognitive impairment. Communication systems might not be appropriate or totally inaccessible for a child with a brain-based visual impairment. Social skills might not be addressed. So since all learning involves visual skills, a poor assessment makes other skills and goal areas completely impossible. So visual fields, there will be a deficit in visual fields if there is an occipital lobectomy that results in a homonymous hemianopia, which means vision on half of each eye on the eye opposite of the resection will be completely gone. Some kids with homonymous hemianopia are considered legally blind. It varies from state to state. Even in a temporal lobectomy, there could be a quadrantinopia. I want to say 25 to 30% result in a quadrantinopia. I might not have that number exactly right, but I think I have it right. A field loss can actually lead to exotropia or esotropia and can ultimately narrow the remaining visual field because the brain is not getting visual input and it leads to further neglect. So again, this is why appropriate evaluation is so important. The neuro-ophthalmologist or the developmental optometrist will offer a perimetry test versus a confrontation test. This is really important because, okay, I just was corrected. All people with homonymous hemianopia are legally blind. It's a federal law in Social Security. So I misquoted that. If the child has a homonymous hemianopia, they are legally blind under the purposes of Social Security. Again, are they legally blind in the eyes of the school district? It depends on if they meet eligibility criteria, meaning does it affect their ability to access the curriculum, which is why we need those comprehensive evaluations. I want to just discuss confrontation versus perimetry testing. The visual field testing that most basic visual evaluations would include, or your teacher, the visually impaired, may conduct would be a confrontation test, which is where you're presenting information to the child and asking them not to turn their head or their eyes and determining what they see. Perimetry testing, which is done by a neuro-ophthalmologist or developmental optometrist, is pretty intense. The child's head is held in like a vice grip and there are dots on a screen and then they have a button to push. And every time they see a dot, they push the button. For a child who has a hemianopia, a true homonymous hemianopia like my son, this test takes a very long time because when you miss the stimulus in the blind visual field, it's repeated over and over again until basically they recognize that you truly can't see it in that visual field. Also, there's a camera on your eyeballs and an administrator is watching the eyeball to make sure the eyeballs are not moving and that the child is looking straight ahead. So it's a very strict measure. It's really the gold standard. If your child has not had perimetry testing, only confrontation testing, and you're being told that they don't have a true homonymous hemianopia, but they've had occipital lobectomy, that's just due to inaccurate testing because it's anatomically impossible for that not to be the case. Please watch Monica Jones' webinar that she did for Perkins School for the Blind on vision after occipital lobectomy and related surgeries. She goes in great detail about these issues. I just tried to give you a brief overview. Again, this is another area that is so important, and that's why I wanted to spend a great deal of time on this today. I'm looking at the time now, and it's already 11:07. So I believe it's been an hour that I've been speaking. I'd like to know if I should keep going. I probably have another hour, so I would be happy to do a part 3 next week or to keep going right now. If you could let me know your thoughts.
Audrey, I think you should keep going and stop right before transition planning.
Okay, great. I will keep going. Okay, so next we have orientation and mobility. This is related to visual impairment. So you would not get orientation and mobility services or assessment if the child does not have a visual impairment. They're going to examine the child's ability to travel indoors and outdoors with or without assistance, and they're going to consider the sensory, navigation, visual, and mobility skills. These are conducted for children of all ages and abilities, including children who are not yet walking, children in wheelchairs, and those who have never traveled unassisted. So an orientation mobility instructor is a professional who has specialized training in how to teach travel skills and concepts such as spatial awareness. They will conduct the assessment. Sometimes there's a teacher of students with visual impairments or a teacher of the visually impaired that is also an O&M instructor and is dually certified in both areas. However, if the teacher is not dual certified, they cannot offer the orientation mobility assessment. They have to have the credential. The teacher of the visually impaired will not be qualified to assess the child's skills and the needs for O&M instruction unless they've received that specialized training. Depending on the child's age, the ability level, and the amount of usable vision, the O&M instructor will evaluate her understanding of the basic concepts that underlie orientation and travel relating to your position in space and location in the environment. For example, the ability to know left from right, inside and outside, up and down, and her awareness of aspects of the environment, such as sidewalks and streets. The child also needs to understand parts of her own body and how they relate to the concepts. They also usually address things like cardinality, north, south, east, west, etc. when the child gets a little bit older. So the instructor is going to look at other skills besides the ability to move in the environment if the skills have an impact on independent movement and travel. So they're going to look at activities of daily living. Can the child store their money, store belongings such as their cane, their coat, and their money independently? Can she use money to pay the bus fare? Social skills. So how does the child interact with others? Can she ask for assistance? So if you have a child with a visual impairment, they need to be able to speak up and ask for help when they need it. If they're offered assistance and she doesn't need it, does she know how to deny it appropriately, to decline it? Planning. So what skills does your child have when it comes to planning a route, whether it's from her classroom to music class or from your home to the neighbors or across town to the public library? Literacy skills. So how does your child make a note of information she needs during travel? Does she print? Does she use an audio recording device to make a list of items she wants to purchase? What about information on the bus schedule, emergency telephone numbers, etc.? And then what optical aids or assistive technology does the child need when traveling? So the child might need a special vision device to see a building number or a street sign, a magnifier. The child might use a cane. Many of our children after hemispherectomy who have a complete homonymous hemianopia use a cane while crossing busy streets. So the orientation mobility assessment is going to assess the child in various environments, static, dynamic, familiar, and unfamiliar environments. There's a lot more, but I'm going to move on to gross motor. So this is generally the physical therapist. They're looking at strength and endurance, balance and coordination. They're looking at functional mobility, ambulation and transfers in the school setting. So the school-based physical therapist is the one that promotes the motor development and the students' participation in their everyday routines and activities, everything that's part of their educational program. So this is all about navigating the classroom and school, accessing stairs independently while carrying school-related objects such as their lunch, their backpack, or supplies during transitions, increasing their ability to participate and keep up with peers in the classroom, recess, PE, and special activities, etc. So all of these should be looked at in the assessment. So the physical therapist will conduct the evaluation. They generally will also have experience in assistive technology, transition, and vocational training. So the physical therapist can be a really important member of your child's team. I note that often children, once they are able to quote unquote access their environment, PT is quickly dropped from the child's IEP, but I would argue that if they can offer input into some of these other areas, the assistive technology, transition, and vocational training, it might be time to bring them back on the team and have them do another assessment. So they're going to assess the motor skills, which is coordination and motor planning, maintaining balance and equilibrium, that's while walking, while making those transfers, while navigating sidewalks, that sort of thing. Gait and ambulation, this is how does she walk? What's her core strength like, and postural control. Functional mobility, which is how do they move around their educational environment, and can they perform educationally related transfers? So that's getting to and from their desk, their chair. How do they get on and off the toilet? Can they get on and off the floor? If it's a younger child that's going to and from the floor a lot, can they get on and off the bus? Can they get on a cafeteria bench? Can they get in and out of the car at the end of the day? And then how do they maintain these positions independently? And do they need alternative positions throughout the day? They look at the child's need for specialized equipment. They look at orthopedic problems. They assess for bracing and also muscle re-education following trauma or surgery, and then prevention and management of orthopedic problems in the trunk and lower extremities. So they're really looking at that range of motion plus positioning and bracing or casting. They may evaluate those vocational transitions skills as well. And the school physical therapist can ensure that your child has access to educational activities, play, and recreation. They may be involved in looking at the child's adapted PE as well, which I'll discuss next. So the assessment measures for physical therapy or gross motor tend to be non-formal assessments. The Bruins-Osaretsky test of motor proficiency is a formal assessment. Some are informal measures. But the important thing to note is that evaluating a child with impaired motor skills requires a high degree of expertise. If your child has cerebral palsy or any motor impairment as a result of epilepsy surgery, their motor, speech, visual, and auditory difficulties are likely to limit the use of any standardized tests. It's not appropriate to test with a time limit for children with weak motor skills unless the goal is to measure their speed of performance. If the child has good hand use and poor speech, the examiner may use tests that use their hands and don't require expressive language. But if they have poor hand use and good speech, the examiner might use more verbal tests, for example. So adapted PE. This is any adapted or modified physical education program that's to meet the individualized gross motor needs or other disability-related challenges of an identified student. The program can be done one-on-one in a small group or within the general PE setting. I want to note that the adaptive PE teacher is a direct service provider, not a related service provider, because special education is a federally mandated component of general education services. This means that physical education needs to be provided to the student with a disability as part of the child's special education. This is different than physical therapy or OT or speech therapy, which are all considered related services. So they are related to the disability. So basically every child is entitled to PE. So the assessments for PE are done by an adapted physical education teacher who's an educationally trained professional able to assess individual students and can develop, adapt, and implement specialized PE programs in the motor domain. The school physical therapist can collaborate and ensure that the child has access to educational activities, but and they also in some schools will be the one that does the adapted PE evaluation. They may either provide the assessment or work with a PE teacher. I would also recommend collaboration with the teacher of the visually impaired and the orientation and mobility specialist if the child has visual impairments, because again, those visual impairments are uncommon, and the adapted PE teacher and the PT may not have familiarity working with a child with visual impairments. They're going to assess the child's ability to participate in PE, to access their school environment. This is all related to their health and well-being. That includes social group and interaction skills, play and leisure skills, their social emotional development, their peer interactions, and sportsmanship. So this goes well beyond just can they throw a ball, catch a ball, or kick a ball. They're going to look at the functional motor skills training in relation to mobility and play. So what training will be needed to help the child with their mobility and their play? They're going to look at endurance and conditioning programs for physical fitness. This is looking at the life of the child, like what physical fitness routine could the child be involved in throughout their life? Balance and body awareness. environmental environmental adaptations. So, for example, does a curb cut need to be painted because of the child's visual impairment, or covered if the child's in a wheelchair? What adaptations to the environment need to be made? And then accommodations and adaptive techniques. This, like all assessments, would result in recommendations that would become a part of the IEP. Very important component of the assessment. Next, we're going to look at fine motor, sensory processing, and activities of daily living. What part of the brain might be impacted to cause impairments in these areas? We're going to look at the motor strip. We're going to look at all those visual functions, which came from both the motor strip and the frontal lobe and the parietal lobe. The OT is going to evaluate the child's abilities, recommend and provide therapy, modify the equipment, and help the child participate as fully as possible in school programs and activities. The assessment will be done by the occupational therapist in collaboration with the teacher of the visually impaired, and orientation and mobility if the child has any visual impairments, as I mentioned before. What is assessed are the child's functional fine motor skills. This is hand control, grip strength, their writing pressure, their one hand and both hand use if the motor strip was affected, their coordination. Visual motor skills. This is looking at handwriting, copying, cutting, etc. Visual perceptual skills. This is looking at spatial processing challenge, visual vestibular integration challenges, etc. Sensory processing, which looks at proprioception and the somatosensory system, which I will talk about. There can be a loss of body sensation after brain surgery when certain portions of the brain are removed or disconnected. It's a very important component. Their tactile, auditory, and visual systems and self-regulation. Their gross motor skills, which includes balance, vestibular, and coordination. So it sounds like maybe that would be a PT thing, but OTs also look at those skills. And then those activities of daily living. Are they able to dress by themselves, pack their school bag, and do they have the strength and agility to do these tasks regularly and well? I just want to mention here too, there's a difference between school-based and OT and private OT. You can have both. Generally, the school-based OT is going to write goals and look at needs in the school setting, and the private OT might look at other areas of need. There could be medical and school implications for occupational therapy. So some processing measures for sensory regulation include the sensory processing disorder checklist, the sensory profile, and a standard measure of sensory processing. These are all more or less checklists. Again, the evaluator really needs to look at, understand sensory processing. Not all occupational therapists understand this. And so if the child has areas of concern in this area, I would ask you to find an evaluator who is trained in this. So I just want to note here that the primary somatosensory cortex is located in the parietal lobe, whereas the motor cortex is in the frontal lobe. The motor cortex sends out signals to different parts of the body. The sensory cortex receives signals from sensory neurons throughout the body. So that's where sensory processing and regulation comes in. Rather than putting out information, it's about receiving information. This is often overlooked by school-based OTs, but there are some standardized measures that can be used, and you need to ask specifically for these to be included. Symptoms of sensory integration dysfunction include deficits in speech, deficits in fine motor skills and coordination. Sometimes they're called neurological traffic jams. They may have motor clumsiness. This could lead to anxiety and depression, or low self-esteem and social isolation and behavioral problems. So children with sensory integration dysfunction often are discovered because they have social isolation and behavioral problems, and then the sensory dysregulation is revealed. This would be done by occupational and physical therapists who are specifically trained in sensory integration disorders. And these diagnoses can be controversial because they're not in the diagnostic and statistical manual. It's not listed as a specific diagnosis code yet. So this is about the ability to take in information from the environment through the various senses, process and organize the information, and use it effectively. So the evaluation would be to measure the sensory integration processes the sensory needs, including the proprioception, self-regulation, and self-modulation. Difficulties in the foundational sensory processing areas, which are the proprioceptive, tactile, and vestibular systems, can impact a child's ability to attend in school. An OT would say they're going to struggle to maintain a well-modulated arousal state without significant cognitive compensation. What that means is they will be tired just sitting up in their chair if they have deficits in these areas and paying attention to the teacher. So that ongoing cognitive compensation can result in a high baseline level of fatigue. And it's experienced daily. This is a background state for the child as they move through their activities. And the effect is most pronounced when additional demands are placed on the child, making it hard to rise to the challenges. So if you're noticing your child is particularly fatigued at the end of the school day, these are some areas that you may want to be looking at. Fine motor skills are measured by the following assessments. Visual processing, again, refers to one's ability to perceive, remember, and think with visual and spatial patterns. It impacts activities such as doing puzzles, solving mazes, and interpreting a graph. And it influences academic achievement in the areas of advanced mathematics and reading and writing. So these are some of the measures that might be used. The Bruininks-Oseretsky test of motor proficiency, commonly referred to as the BOT, looks at the visual motor, functional fine and visual motor. It looks at fine motor control. It has manual dexterity subtests in looking at producing dots, transferring pennies, placing pegs into a pegboard. And it also looks at things like coloring, completing mazes, copying shapes, and cutting skills, etc. The developmental test of visual perception has subtests that measure visual perception and visual motor abilities. They're going to be looking at all of those areas for general visual perception. Speech and language. Communication is central to a child's education. And speech and language disorders and speech impairments often have an adverse impact on a child's educational performance. Children with motor strip, frontal lobe damage, disconnection, or removal may have motor issues like dysarthria and apraxia. Frontal lobe deficits may impact executive function and organization. And remember, higher order language networks can be disrupted with the removal or damage to any lobe of the brain. We've talked a lot about those networks and how any disruption can cause a problem. So a comprehensive speech and language assessment will determine current levels of functioning, determine eligibility for speech and language services, and assess for a specific learning disability. Speech language impairment is a disability category under IDA. And we're also want to be sure that we look at augmentative and assistive communication. This was covered in our previous presentation, A Beginner's Guide to IEPs After Epilepsy Surgery, so I'm not going to discuss AAC today, but it is part of the child's ability to access communication within their school day. Very important. So speech and language pathologists, also known as speech therapists, are specialists in the study of human communication, its development, and its disorders. So they would be the ones that would assess the child's speech, language, cognitive communication, oral feeding and swallowing skills, communication problems, nonverbal communication, this is very important, how they use language in context, social skills and pragmatics, review their hearing, visual, motor, and cognitive status, identify any other factors that may contribute to a speech disorder. Other people who assess language skills are the neuropsychologist, the audiologist, the school psychologist, and a learning disability specialist or special education teacher. But only a speech and language pathologist can assess for language disorders. However, there's a close relation to hearing and central auditory processing disorder. So an audiologist should evaluate your child's hearing to make sure hearing problems are not contributing to the child's speech and language difficulties. They can, this assessment is very important in the development of vocabulary and social skills development. So there's different areas of disorder. If they have a speech disorder, they're going to look at difficulties with articulation, are fluency, which is the ease and accuracy of their speech, and their voice, which is their pitch and their harmonics. Speech and articulation tests include tests of phonological disorders, as well as apraxia tests, which look at oral motor skills, which could be impaired after a motor strip disconnection, that pitch and intonation when speaking, and pronunciation of speech sounds. Testing of oral skills, which is that frontal lobe motor strip again, looking for signs of weakness or low muscle tone in the lips, jaw, and tongue. They're going to make the child move the tongue, smile, and frown, and see how they coordinate the movement of the mouth and how this might impact their ability to speak, and evaluate the coordination and sequencing of muscle movements. Testing for the pronunciation of speech sounds, which again is the temporal lobe or auditory cortex, would evaluate the child's ability to make vowel and consonant sounds, test their ability to say individual sounds and sound combinations, and determine if others understand your child when he uses words or phrases in conversational speech. So you can see how those areas would be impacted by both the motor component and the auditory component, because if the child can't hear the sounds properly, they're not going to be able to make them properly. And if they can't make the sounds because of an oral motor deficit, they're also going to have challenges with that pronunciation. So we really need to look at both. Receptive language disorder is often called a language processing disorder. These children may have difficulty, they may misunderstand what people say, have trouble following spoken directions, or have difficulty organizing their thoughts. Some children with receptive language disorders have auditory processing disorders. Many children with language processing disorders may appear to have attention deficits, but ADHD might also be a coexisting condition, which we've discussed before. So measures of receptive language, they look at the vocabulary and their spoken language. Here are a number of tests that might be used in this area. Expressive language, they're going to have difficulty putting words together in sentences, proper use of tenses, such as past, present, and future. They might have difficulty finding words and organizing their thoughts. Their writing might be poor, and they have difficulty in conversations and classroom discussions. Here are some measures of expressive language. They're going to be looking at how they speak. They're going to be looking at some of those phonological components as well, and their vocabulary and language development, and also tests of problem solving, because there are higher order language functions involved in expressive language. Pragmatics is difficulties with taking turns in conversation, making eye contact, maintaining appropriate personal space, saying inappropriate or unrelated things during conversations, telling stories in a disorganized way, or having little variety in language use. This is basically a social language disorder, and many children with disabilities will have a difficult time making friends, and this, you can see how these deficits would make it very hard for other children to want to be friends with this child. The goal of IDEA is to gain employment and live independently, as we've stated. It's difficult to get a job if you can't converse. It's hard to grocery shop if you can't communicate effectively, and you can't have a social life if you don't have friends. So the assessment measures for pragmatics are often what would you do questions. On the test of pragmatic language and the comprehensive assessment of spoken language, the evaluator will ask the child to describe how he makes introductions, requests help. How do you make a hint about something? How does the child adjust her communication style in different settings? And then they'll assess social language skills. This is all done in a non-natural setting, though. I'd like to comment that an assessment of pragmatic language should always include informal observations of the child in different environments, at home, at school, and in the community. Because if you're just doing pragmatic language measures one-on-one in a speech therapy room, you're not actually assessing their ability to use the language in context. What I often see is the child does a great job in the therapy room when the speech therapist says, "How would you do this? What would you do in this situation?" The child might list perfectly exactly what they're supposed to be doing. And then they walk out to the playground and they do None of those things. Part of this is because our kids have a hard time generalizing skills, which means taking skills from one environment to the next. So it's really important to assess the child in different environments, and it may be important to actually provide these pragmatic skills training in the different environments as well. So educational decisions are never based on one test or subtest, which we've talked about before. Multiple assessment measures are needed, and we need to know what tests are being used and if they're appropriate. I want to mention here that the core subtest test of the clinical evaluation of language fundamentals, which is a common speech and language assessment, does not measure pragmatics. The pragmatics profile that's part of that does. So again, you want to know what tests are being used and if they're measuring the right thing, if they're appropriate for your child. AAC was discussed in our previous presentation, so I will not discuss it today. However, it's a very important part of communication for the child that is nonverbal, pre-verbal, semi-verbal, and it definitely needs to be looked at. So now we're going to look at assistive technology. Our assistive technologies are devices and services that will help improve your child's ability to function and learn. So after brain surgery, children may have difficulty performing activities of daily living on their own or even with assistance. They may have difficulties with reading, writing, and math. They may have problems with their vision, hearing, listening, or communicating. They may have physical, mobility, and motor problems. Assistive technology can help children use their strengths to compensate or work around these weaknesses, and they can enable the child to accomplish tasks at home, in school, and in the community. So a wheelchair is an assistive technology that provides independent mobility for a child who can't walk. An assistive technology can be something as simple as a magnifying glass or a pencil grip. It can be as complicated as an eye gaze activated computer. The technologies help the child access their curriculum. It increases the child's opportunities for education, social interactions, and potential for meaningful employment. And it can also help minimize the academic demands on the child by using tools and supports to free up the child's physical and cognitive resources for learning. I've talked before in the previous evaluations how when these underlying skills are damaged or impaired, when you think about how much effort it would take the child to perform some of these tasks and how fatiguing it can be throughout their school day, this is where assistive technology can come in. What supports can be put in place to lessen the burden of the various impairments that the child might face? We want to support the student in the least restrictive environment, and assistive technology can help support that. The law requires that AT is considered for every child with a disability, and provided if it's required for the child to access a free and appropriate public education. So if you or your child's IEP team don't know what assistive technologies might support your child, ask for an evaluation. Our kids can generally benefit from a full range of assistive technology devices and services. So remember, assistive technology includes devices and services. Often teams only look at the device and not the service. So who assesses? The assistive technology, a specialist. They have special knowledge and expertise in AT. If your child's needs are complex, I would definitely ask an assistive technology specialist to join the IEP team and to do the assessment. Sometimes other providers would be involved. Again, if the child has a vision impairment, the teacher of the visually impaired and the orientation mobility specialist might be involved. If the child has an auditory impairment, central auditory processing disorder, or other auditory impairment, then the audiologist or the teacher of the deaf and hard of hearing might be involved. So you want to make sure that the assistive technology is being looked at from all areas of need. Assistive technology tools and services must be identified as educationally necessary and documented in the student's IEP, and this is done via the evaluation. So the evaluation would include a functional evaluation of your child in school or at home, which means the evaluator needs to look at your child using different devices in different settings across their school day. So going in one time to one class and looking at how the child uses a computer and saying, doing great, that is not an assistive technology evaluation. Again, never one measure. And we want to look at the whole range of services that might be possible for the child. They're going to review the need for the devices or services. And generally, I see a lot of schools using the SET framework, which you can look up online. That's the most often employed framework that's used. There are not specific assistive technology measures, but it is required that there is a comprehensive evaluation in this area under IDEA. You want to include the evaluation results in the IEP, including the recommendations. So again, every assessment has to have recommendations. So I'm going to show you on the next slide a very overwhelming list. I'm not trying to overwhelm you. This is a list of possible assistive technology devices and services. They can range from high tech to low tech. I put this up here just to show you an idea of things that could be used. There is no list because the assistive technology device and service is based on the needs of the child. What does your child need to help support them, to help minimize their impairments in the school setting, to help them access their curriculum and interact socially and recreationally within the school setting? Functional behavior was covered at length in our first presentation, A Beginner's Guide to IEPs After Epilepsy Surgery, so I am not going to cover that here. Mental health. So the school is required to assess your child when educational progress is affected by social and emotional issues, communication challenges, and other factors. Some parents are apprehensive about the term mental health, but many students with disabilities may need access to mental health supports. Children with disabilities often recognize their disabilities and the ways in which the disabilities make them different from their peers and separate. They may experience behavior and other problems in the classroom that interfere with their educational progress because of this awareness or for other reasons. A mental health disability can include ADHD, emotional and behavioral problems, which result in the inability to make and keep friends, which results in isolation from peers or frequent altercations with peers. They may struggle with issues of self-esteem, social isolation, anxiety, or depression. All of these interfere with the ability to access instruction that's provided by the school. Mental health services can provide a bridge for those social and pragmatic deficits we often see in our kids and help with social awareness and maturity and behaviors. It can help the child develop coping strategies and address feelings about being different, develop self-esteem, and even mindfulness techniques. Schools are legally mandated to look at the whole child and the child's overall educational development and assess for eligibility in a multitude of performance areas, including their social and emotional development. Social skills development is part of the educational process. So just to think about potential services that might be a result of this evaluation, which might make it more appealing to request this evaluation. So psychological services is defined not only to include psychological testing and assessment, but also consulting with other staff, assisting in developing a positive behavior intervention strategy and strategies, and planning and managing a program of psychological services, including counseling for children and parents. So the child may receive school-based counseling. The parent might receive counseling. There could be social work services, which would be looking at the social and developmental history of the child, providing that group and individual counseling, and working in partnership with the parents and the whole team to look at all the issues that affect the child's adjustment in school, and even mobilizing school and community resources that can end up being wraparound services that can include the mental health diagnosis, outpatient therapy, or medication management. Schools also have to consider, does this child require day treatment services, meaning services provided at school, residential treatment, or inpatient hospitalization? If that's what the child requires based on their mental health needs, then that's what needs to be provided. So the mental health assessment needs to be conducted by someone who can determine mental health needs. Therefore, a classroom teacher or administrator would not have the expertise. It's generally conducted by the school district psychologist. A neuropsychological evaluation will often pinpoint areas of deficiency here and help identify any necessary strategies, and they may also be able to provide a specific diagnosis, because remember, school evaluations don't diagnose. This assessment determines whether the child's disability may be serious enough to warrant special mental health and therapeutic interventions, and this would be to enable him to make friends and socialize appropriately. Does this child's impairment substantially limit their ability to learn? There are a number of tests that might be done to determine the areas of need here. So health and medical. The related services definition in the IEP and the IDEA, includes medical services for diagnostic and evaluation purposes, and other medical services are beyond the scope of IDEA, which means that the school may be required to pursue diagnostic and evaluation services for a student whose unmet needs are interfering with academic and interpersonal success, but monitoring medication has typically been regarded as a medical service that goes beyond diagnosis and evaluation, and therefore excluded from a school's responsibility. So school health services and school nurse services are designed to enable a child with a disability to receive FAPE as described in the child's IEP. The nurse services are generally provided by a qualified school nurse, and health services are provided by either a qualified school nurse or other qualified person. So a health assessment, generally the school district nurse, in collaboration with the student, family, educators, school staff, other healthcare providers as appropriate, will determine the child's medical needs at school and on field trips or in any other setting that is school related. They're looking at that general health exam, looking at basic health, visual acuity and hearing sensitivity, reviewing medical records, a written report from the physician indicating the medical history, any medical needs, write the health protocol for the school nurse, and the nurse would implement the health protocol provided by the doctor. And they also would develop a seizure action plan, a complex care plan, or an individualized health plan, which I will talk about, and identify goals, services, and supports that are needed in the IEP. So for example, your child may need a goal around self-advocacy to remember to take their own medication during the school day if they're an older child. That would be part of this. An individualized healthcare plan can be developed as part of the IEP. It may be attached, but not in the IEP, so it could be ignored or forgotten. So I'd really like to see an individualized healthcare plan in the IEP. Let's list, it's going to give all the necessary medical information about the child. We want to make sure we list symptoms of hydrocephalus and seizures. What's the shunt monitoring protocol in school or shunt failure protocol? It should define the access to school and health and nursing services. So what level of nursing services? Where's the emergency medication kept? Who do we contact in an emergency? What constitutes an emergency? Who's trained to administer seizure medications, etc.? It should have an emergency care plan and a field trip plan. This goes well beyond just a seizure action plan. There are standardized, individualized healthcare plans that you can find online, but again, individualized is the key word. So you are never beholden to what is on a form. You want to write the plan that is appropriate to your child. So I'm going to end there today. We will offer a part 3 on transition at a later date. We have many resources available on our website, so please take a look. And if you have questions, feel free to send us an email. Thank you for your time.